Trying to conceive and feeling overwhelmed and confused with unhelpful information and advice? This podcast is for you. Welcome to Don't Tell Me to Relax. I'm your host, Hannah Pern, a fertility acupuncturist and passionate advocate for better fertility education and support. Our aim is to empower you with information to support your fertility journey and provide a community for connection with people who get where you're at. If you'd like to join us or work with us in clinic in London or across the UK, all the information is in the show notes at the end.
AcuPips sponsors Don't Tell Me to Relax. If you're looking for a way to naturally balance your body, calm your mind and relieve anxiety, then AcuPips has the answer. AcuPips is the UK's original ear seed company, founded by traditional acupuncturist Zoe Young. Ear seeds are small seeds or metal balls attached to an adhesive and placed on pressure points on the ear in specific combinations, creating balance within the body. We like to call it healing jewellery. Discover more today at acupips.com and use code RELAX for 20% off site-wide. AcuPips. Modern healing, ancient practice.
Hello and welcome. Today I am joined by Professor Shehata. Professor Hassan Shehata is a renowned consultant obstetrician and gynecologist specialising in maternal medicine. He is the CEO and Medical Director of the Centre for Reproductive Immunology and Pregnancy Clinic in Epsom, and he has dedicated his professional life to investigating and treating recurrent miscarriages and addressing challenges associated with failed IVF. So, Professor Shehata, welcome to Don't Tell Me to Relax, and many thanks for giving us your time today, especially as it is your 60th birthday.
Good afternoon, and thank you very much, Hannah, for the kind introduction and the kind invitation. I'm really thrilled to be here, and I know it's my birthday today, but I couldn't miss the opportunity to help with information to your clients.
Great, because that's what we're all about, is about getting information out to as many people as possible. So let's start really right at the very beginning, because your centre is called the Centre for Reproductive Immunology. So can you explain to us, what do we mean when we talk about reproductive immunology?
Thank you, Hannah. It's a very good question. So, as you know, when we look at our constituents of blood, we have three main constituents. We have red blood cells, which carry the oxygen and give us the red color of the blood. We have platelets, which, if we are cooking and we cut our fingers, it kind of blocks it from bleeding too much. And we also have the white blood cells, which is responsible for the immune system. Now, the immune system works in different parts of the body. One of the areas that I have particular interest in is called reproductive immunology, which means that the immune system that is related to reproduction. And reproduction means getting pregnant, keeping the pregnancy, trying with IVF, etc. So basically, it is the science of these cells that could be either helpful or sometimes obstructive to someone getting a successful pregnancy outcome.
And so you work a lot, obviously, with miscarriage, recurrent miscarriage, IVF failures, repeat IVF failures. So what people often ask us, because we have worked with many people who have worked with you in our clinic, and many people sadly come into our clinic having experienced miscarriage and feel very confused, lost, overwhelmed with where to go. So often people are told lots of different bits of information. So first of all, in your opinion, when we talk about miscarriage and recurrent miscarriage, can you explain, what do we mean by that? Because often the definitions are different in different places.
I think this is really important, Hannah. So, what we mean by a miscarriage is losing a pregnancy at any stage up to 24 weeks gestation. And we divide them into first trimester loss and a second trimester loss. Now, when we come to first trimester loss, what we mean by that is a pregnancy loss before 13 weeks. I tend to subdivide as well to less than 6 weeks, which we call chemical pregnancy, and then between 6 and 9, which is first trimester loss. And I think if you have a 9 completed week size plus, that will be a late loss. Now, the commonest cause of a miscarriage is a chromosomal or genetic abnormality, but it is not a common cause of recurrent miscarriage. And I think this is really quite important to explain. So, the so-called bad luck is a genetic abnormality. So at the time of fertilization, between a sperm and an egg, sometimes the genetic material get muddled up and cause a miscarriage. The commonest type known is something called trisomy 16, which means in chromosome number 16, there's an extra genetic material that makes the pregnancy incompatible with life. Now, the older we are, both as women and men, the higher the incidence of having a miscarriage related to a chromosomal abnormality. So, for example, at the age of, say, 25 to 30, that risk is about, for a woman, the risk is about 1 in 5. And as we reach, say, 45, that risk is 1 in 2, and anything in between. So it makes sense, therefore, to say, well, if you do have one miscarriage, it could be bad luck, i.e., chromosomal abnormality. However, when you come to recurrent miscarriages, that's a completely different ballgame, because we said already that at the age of 25, 30, 35, the risk is about 1 in 4, 1 in 5. Therefore, you can't explain somebody having 4 and 5 and 6 and 10 miscarriages. I've looked after couples with 20 and 30 pregnancy losses. So there cannot be chromosomal abnormalities happening again and again and again. Statistically impossible. So therefore, the investigations into recurrent miscarriage is completely different. You need to look at a possible pathology that happens again and again and again. And sometimes it really frustrates me, Hannah, that sometimes people are advised to have a genetic test as a part of the investigations, because a lot of these so-called genetic abnormalities are usually sporadic. They're not hereditary. It's not something that you carry or your partner carries. And as we know on the NHS, these tests take a while to do because they're done normally in tertiary centers. And therefore, we find couples waiting for months and months and months and then get referred again, sometimes wrongly, to the geneticist. And when they see the geneticist, who is the expert in that field, say to them, I don't know why you're here. This was sporadic. And therefore, they've lost 6, 9, sometimes 12 months waiting for that. We also have, bizarrely, advice by authorities in the UK is that if you have a third or a fourth miscarriage plus, the products of conception should be tested for genetic abnormalities, which doesn't make sense at all, because again, you're going to find a sporadic abnormality. It doesn't tell me why you've had the other 3 or 4 before. And then you end up in that kind of dilemma of getting investigated and wasting time and so on. So a miscarriage, it could be any cause, including chromosomal abnormalities, but a recurrent miscarriage is invariably not related to genetic abnormalities. I have to put a caveat here. We have very rarely something called an unbalanced translocation we find sometimes in a miscarriage products of conception, which is a possibility that one of the parents would have been carrying something called a balanced translocation. And when it goes to the pregnancy, it becomes unbalanced and causes a miscarriage, because the balance is fine, because that mother or father are living with that balanced translocation. But if it becomes unbalanced, it can cause a miscarriage. And depend where that balanced translocation is on the genetic spectrum, the risk of miscarriage ranges between 5 to 20%, depending on where it is. And therefore, as a positive person, I flip it around and I say, well, actually, you have an 80 to 95% chance of success. So why worry about it in the first place? And therefore, why test it in the first place? And you have to test at least 300 to 500 women and men to find one test of with that balance translocation. And unless they have a fertility problem, our advice normally is to try naturally. Very commonly, these couples, when they found these abnormalities, they are advised to have IVF with something called pre-genetic testing. You probably know that from your patients. And they go and have the test on the embryo, put a normal embryo back, but they still miscarry because the original pathology have not been addressed.
So can I just ask, because again, like from an NHS perspective, recurrent loss is often described as 3. Like lots of people have to wait until they've had 3 losses before they are allowed to have further investigations or be referred. What would you advise if somebody? Do you think that is the right cause, or do you think it's better to investigate sooner?
Excellent question. So first of all, there is nothing on the NHS that says that. So these are actually clinics decide where their criteria is. So, for example, in my NHS practice, based at Epsom and St. Heliers, and I'm more than happy to see patients from all around the country because we have a tertiary center. We are happy to see people after 2 losses. We don't wait for 3, because my view is, especially nowadays, sometimes some couples are delaying getting pregnant for later in their 30s, early 40s. And why should they wait for another miscarriage? So that's my personal view. I know some units insist on 3, some units insist on, are happy with 2. Now, another important, really point I would like to make, that if a couple have had a loss that is 9 completed weeks size, i.e., 10 weeks plus, they should be investigated after 1. They shouldn't be waiting for 2 and 3. That's different if you lose a pregnancy at 12 weeks, but the pregnancy stopped at 6 to 7, what we call a delayed miscarriage or a missed miscarriage. But actually, if the pregnancy carried on until 9 full completed weeks, they should be investigated after 1, because the chances of losing a pregnancy at that late stage is the same as losing a pregnancy more or less at full term. And we would investigate that.
Okay.
So my advice to your audience is that look for units, or ask your GP to look for units that accept 2 miscarriages or more. We certainly accept them. Or if you've had 1 that is quite late, then you should be investigated after 1.
Okay, that's really, really interesting and useful. And another thing that we see a lot is that people are referred to their recurrent miscarriage clinic. They have a lot of blood tests done, and they are then told, we can't find anything, try again. And that seems to be, and people feel like so frustrated and so lost in what do they do next, because they feel like they've been in front of the experts. This is the recurrent miscarriage clinic. They've done lots and lots of tests, so they feel they've been investigated, but nothing has come back. And it's such a difficult position.
This is a very good question, Hannah. So, first of all, I think all miscarriage clinics in the country, they try their best to help their patients. So I think that's really quite important. There is a problem with the training of our clinicians and nurses and midwives who are involved in miscarriages, as to have expertise in recurrent miscarriage. Because one of the things I would like to do, wearing my hat as the senior vice president of the Royal College before I finish my time in December next year, whether we can actually introduce specialist training for recurrent miscarriage. Because at the moment, we teach recurrent miscarriages as a small module, part of a full kind of gynecological practice that includes early pregnancy, ectopic, etc. So I don't think there's enough expertise there. So most of the patients who go to these recurrent miscarriage clinics are either seen by fertility specialists who have an interest in recurrent miscarriages, or general gynecologists with an interest in recurrent miscarriages. So that's number 1. Number 2, I think one of the major issues is that historically, the main causes of miscarriages were thought to be, number 1, sticky bloods, or what's so-called thrombophilias. Number 2, a deficiency in progesterone, which we now know, and I'm hoping we're going to discuss that in more details, they're not really that as an important cause, if any, at all. And therefore, you end up in a place where they're still doing these investigations, and invariably they come back as normal, or even if they're slightly abnormal, it doesn't help because you're actually treating something that is not a cause of miscarriage. Still, some couples are getting investigated for genetic testing, which we now know is not important. Some patients are getting investigated for anatomical abnormalities, which I personally do not think it has an important role in a first trimester loss, maybe in a late loss or a second trimester loss. But it doesn't really explain if you have a small septum at the top of your womb and you've had 20 miscarriages. Why? Why is the pregnancy going to stick to that bit every time? So I think it's all about logic and common sense. So one of the things I have tried to do over the last couple of years is to tackle some of the well-known pathologies, if you like, as a cause of miscarriage, and prove that they are not really a cause of miscarriage, to try to get the experts in the field to sit together and address the issue. So I use, for example, let's talk about progesterone. So uh, there's been a couple of studies done in the use of progesterone, big trials, which showed that progesterone doesn't help in patients with recurrent miscarriages. Another big trial was done that showed that progesterone doesn't help with threatened miscarriage. But then sub-analysis of the data was done between the two studies and suggested that actually if you give progesterone to somebody who had 3 miscarriages before and on their 4th pregnancy and they may be bleeding, maybe progesterone will help. But actually, the original trial showed no evidence. It becomes therefore wishy-washy. And of course, then get even more complicated for the treating physicians and the patients, because then the NICE guidelines come and say, if you've had 3 miscarriages and you're bleeding, take progesterone. There is no evidence for that because the original trials were not powered for that. The same we have now with regard to use aspirin and heparin, etc. I think this is a big issue we have, not only in the UK, but all around the world. But I'm happy to speak about that as well when we talk a little bit more details about what possible treatments are there.
Can I also ask as well, because often surprised when I work with somebody and they've had like lots of investigations done. And obviously, most people who I see in my clinic are female. And I say to them, well, has your partner had any investigations? And they say, no. And so I'm always quite amazed that, someone can go through, quite a lot of investigations as a couple, but the man has not been investigated at that point.
Absolutely. And of course, if you go for IVF, the man gets investigated until kingdom come. But for some reason, in miscarriages, everybody assumes it's the woman's fault or the woman's body. Um, I always say it takes 2 to tango. So it's really important. Now, here are the issues we have when it comes to men investigations, because men investigations of recurrent miscarriages, Hannah, have lagged behind big time. We are now also trying to demystify some of the myths that we know about possible causes and treatment for women when it comes to recurrent miscarriages. So for men, there is a new test that we tend to do. Is called sperm DNA fragmentation test. So the traditional semen analysis, i.e., how many sperms a man has, how many, so what they look like and how they swim, is not important for a couple who do not have a problem falling pregnant. Um, when it comes to miscarriages, there has been a link found between high abnormalities of sperm DNA within the inside of the sperm damage. We published a paper ourselves. But, and I think it's really important to this but with a capital B, and we need to inform our patients. Although we have shown in some trials benefit of intervention, i.e., lifestyle, stop smoking, have antioxidants, etc., multivitamins, what we have not shown that even when the sperm DNA improves, that is translated into a better live birth. And I think that's where the dilemma is. So I think one of the restrictions, therefore, the NHS will have, and I have that in my practice, that I cannot do the sperm DNA because at the moment the evidence is not there to say if I do this test and treat this man, that will yield a higher success rate. So we need more work. But I agree with you. We still do the test because every single study that's been done around sperm DNA have shown a link with recurrent miscarriages. What we lack at the moment is more research into reversing that. What are the best options? What are the main causes, like infection, varicose veins, etc.? And if that is kind of translatable into a better life birth.
Mm. So if someone comes to your clinic, whether NHS or privately, what are the tests that you would run? And yeah, let's start there. What are the tests that you would do if someone was sat in front of you with recurrent loss? Where do you start?
So and I start with the NHS. So on the NHS, we will do a natural killer cell test. So we are lucky that we offer that on the NHS, a baseline natural killer cell. We've published several papers. So there's a lot of people there who do not believe in reproductive immunology, but I can tell you there's more publications on the link between natural killer cells and miscarriages than there is for thrombophilias and progesterone. Um, Now, We do something called peripheral natural killer cells, and I know that some people believe in endometrial. We'll come to that discussion later, but we offer that on the NHS. We're lucky to offer that on the NHS as a first line baseline natural killers. We also look at thyroid antibodies, anti-nuclear antibodies, something called ENAs, a lot of antibodies we look at. So that's the main chunk. We also do hormonal profiles. So we look at thyroid, prolactin, polycystic ovaries, because there has been shown a link with abnormal hormonal profile. And we will also do occasionally, sometimes, especially those who have a late loss, anatomical assessment, but not routinely. We do not have the facility to do sperm DNA fragmentation in our NHS practice. And then a baseline well-being, full blood count, kidney function, liver function, in anticipation of treatment. We will talk about what treatments we give. And in the private sector, we will do exactly what I just mentioned. But on top of that, we look at a more sophisticated natural killer cells. So we look at natural killer cells in a pregnancy environment. So actually, we simulate pregnancy in the sample we have. We also do test on something called cytokines that affects implantation, very early chemical pregnancies. And so these are the two extra tests that we do not have on the NHS. And then for the man, we will do the sperm DNA fragmentation. So subtle changes, but we are able to do some on the NHS. Luckily for our patients, we are probably the only hospital that does the peripheral natural killer cells on the NHS.
And I presume when you're talking about the tests, you're talking about the blood tests that are done at St Heliers,
Correct.
St Helier Hospital.
Correct.
And so, what often people ask us questions about is the difference between the St Helier test, and often people hear about the Chicago test.
Yes.
And there's different people have different opinions about which is the best one. And can you just clarify that, because it's
I think it's very. So let's talk about the St. Helier test. So this one is done on NHS quality control. So number one, I think automatically you know what you're getting. So definitely a better test, because we know nationally we have guidance on how our labs are assessed. So we have very few countries that we have a national oversight of how we do the test. So that's number one compared to tests done in America. Number two, when we did the research, and I published several papers on natural killers, and we had several kind of students who've had their PhDs and MDs done under our supervision, we found that the natural killer cells are very fragile. So one of the issues I have with the test going elsewhere is that imagine having a sample done somewhere in Surrey or London, then pack that up, car or bike to the lab, then a bike to Heathrow, customs, plane, arrive, customs, another bike to the lab. But, if you've been to the States, if you've been to Chicago, we arrived knackered. Imagine a small cell. So one of the first things we have recognized that actually natural killer cells are very fragile, and it becomes almost uninterpretable after 14 to 16 hours. So therefore, we believe that it has to be done afresh. Otherwise, you're not getting the right result. So I don't have a problem with the Chicago lab. If you go to Chicago and do the test there, that's fine. But to have a sample done somewhere, and then for that sample to do all this waiting time, I'm not sure how reliable is that. Does that make sense?
does, yeah. So I'm interested, why do people do that test then?
I don't know. We have a test that is available on the NHS. Is it reliable? I think just people get used to it. In Harley Street, I think that Chicago lab is one of the early labs that started to offer the test. So so it's like vacuum cleaners. Hoover's still the best name, isn't it?
And what about the test with the endometrial? Is it the endometrial tissue, endometrial blood? I've heard a few people have that test done.
Yeah. So when we started doing research into natural killer cells, Hannah, one of the things that made sense is actually take it from the endometrium. It makes sense because it's the easier thing. But what we have found, two problems. Number one, when we took a sample from the same woman, and this is going back to 2004, 20 years ago, took a sample from the endometrium through a PIPEL, which is an invasive procedure. That's number one. Number two, we had different results if we took it at different times of the cycle. And we also had different results if we take it at the same stage of the cycle in different months. So it it became unreliable. Then our lab technicians said to us that what they found that actually to try to separate the natural killer cells from the rest of the tissue around it made it very difficult technically. And as I mentioned before, natural killer cells are very fragile. So invariably, they would have damaged other natural killer cells. That's another problem. And then the third problem, they said also, because when you touch the endometrium, because the endometrium is very fragile, that's how a woman gets a period. It's a hormonal change, the endometrial change, and you shed your endometrium. When you touch the endometrium with a pipelle, you scratch it. And they said, we're not sure if we're double counting. Is this natural killer cell coming from the endometrium, or is it coming from the blood? So therefore, we there change our concentration, our research into the natural killer cell functionality. I know some people say, well, actually, you can't do that with peripheral natural killer cells, but we do, because that's why we name them CD16, CD69, etc. So it's like if somebody comes from Mars and look at us, they will see, Hassan wearing blue glasses, Hannah wearing red glasses. They will know the difference between us. It's just the same. So these cells, we have something called cluster of designation, CD, 69 and so the machine will differentiate between a lymphocyte and a natural killer cell automatically by the software that is built in.
Mm. And so if somebody they come to clinic, they have the test done, they're found to have these raised level of an activity of killer cells. So what happens next?
So the most important aspect of our approach really, and why we have a high success rate, is mainly starting treatment preconception. So to start treatment at positive pregnancies, it doesn't work. So this is really, really fundamental. When I started working on recurrent miscarriages, historically, women were only given treatment, and sadly, still some units do that, like progesterone or heparin injections. Obviously, we can agree or disagree, it works or not, only when they see a baby's heart at 6 weeks. So actually, when you see a baby's heart at 6 weeks, your risk of miscarriage drops by 67% anyway. So actually, are you really treating someone who needs support? So the most important thing, in my opinion, is starting treatment preconception. So even in the couples we look after who've had a successful outcome under our care, if they fall pregnant the second time unexpectedly before starting the treatment, and they only start at positive pregnancy test, almost always they miscarry. So that actually proves the point, you need to start preconception. So we will offer treatment depending on the results. So we have a number of medications we use that are tablets. So I use something called prednisolone, which is a steroid. I use something called hydroxychloroquine. I'm probably the first person in the world to use hydroxychloroquine for recurrent miscarriages. We use something called tacrolimus or tacrolimus. That's a drug we use for very complex cases, mainly people with late losses and conditions like chronic histiocytic enterovolusitis, CHI. And then I tend to use progesterone, but I use progesterone preconception and not for hormonal support, because I don't think it works hormonally. And I don't think it works from positive pregnancy test, but mainly because it also has an immune modulation effect. So and you can use either a pessary or a tablet. Then we also use something called intralipid infusion. And intralipid is a fat extract from eggs and soya. It has been shown to calm down the immune system. We also use it to neutralize toxins in anesthesia, etc. Um, and I don't use intravenous immunoglobulin. I know some people use that. I think IVIG is expensive. And at the moment, really, all the trials only used in research have not shown that it is superior than anything else that I use. And also, it has a huge cost implication. I also use something called GCSF occasionally, but these are the kind of the tacrolimus, the GCSF, these are like second and third and fourth line medication. So the majority of the drugs we use are prednisolone and hydroxychloroquine and occasionally intralipids.
And people can do this while trying to conceive naturally. It doesn't have to be alongside IVF treatment.
IVF is not a treatment for miscarriage, Hannah. Thank you for bringing that point. So there's a lot of couples we see who are wrongly advised that they need to do this IVF with selecting the embryos, pre-genetic testing, etc. And they put the embryo back, and you've probably seen these couples, they end up with a miscarriage because the original problem have not been sorted. So IVF very clearly have shown no improvement in patients with a recurrent miscarriage problem, only no fertility issues, in providing a higher percentage of live birth, and it does not reduce the risk of miscarriage. So IVF is a no-no. So we use the treatment with a natural approach. So we start preconception. It's important to understand that prednisolone obviously has side effects. So we normally use it for 10 days from ovulation. You do a pregnancy test, and if it's negative, you stop it and you start again the next month. And the dose has to be treated according to the patient weight, the possible side effects, etc. I always like to combine that with an antacid like omeprazole. Hydroxychloroquine, on the other hand, is a slow burner. So that needs to be built up gradually. So you take it all the time. We'd recommend a period of 4 to 6 weeks before you start trying. So these are really quite important to do that way.
And in terms of like taking steroids and drugs that are modulating your immune system, what are the impacts of that for the person taking them, first of all? And are there any, so I've got two questions. So for the person taking them, and then are there any impacts in terms of pregnancy and birth and the child? Sorry, that's
No, no,
quite a few questions.
no, no, very good question. So let's start with, first of all, the duration of medication. So our duration of medication, that we start kind of winding things down by the end of the first trimester. So the prednisolone, we normally start weaning off at 12 weeks. The hydroxychloroquine will stop it at 16 weeks. So that's really quite important. Now, you need to explain to the patient the side effects. You need to be responsible and have the expertise of using prednisolone. So, as a maternal medicine specialist, I use prednisolone for a lot of things. Severe pregnancy sickness. I use it for patients with Crohn's disease, ulcerative colitis, asthma. So, you need to have that expertise. I've recently come across a patient who was giving prednisolone, miscommunication, wrongly advised to take a dose of 20 milligrams continuously all the time while she was trying. Eventually, her periods have stopped because that's what it will do. Therefore, you need to actually have the expertise. So, side effects wise, you need to explain. The commonest side effect we come across with prednisolone in the mother is insomnia, because it gives you a buzz of energy. You hear about athletes cheating by taking steroids. Um, One of its effects, rather than a side effect, actually, it masks symptoms of pregnancy. You don't feel pregnant because it's a good treatment for severe pregnancy sickness. So that's another important thing you need to say to the patient. Say to the patient or to the lady that if you don't feel pregnant, don't assume it's bad news. Because, women, as you know, who've gone through recurrent miscarriages, they're very in tune with their bodies. They know every single sign and symptom. And of course, because of their bad experience, they will always think negatively. So it's really important to tell them in advance that is not the case. Weight gain is mainly about food choices, because it improves your appetite. So we advise them about that. Um, and what we tell them to do is as well that if you're on a certain dose of 20 to 25 milligrams, if you're on it for about 2.5, 3 weeks, you cannot stop it abruptly. You need to wean off gradually. So if unfortunately the woman ends up with a miscarriage early, then you can't just stop it like that. Or if you're winding it down at 12 weeks, you need to stop gradually. So normally we drop by 5 milligrams every 5 to 7 days until they eventually stop. Otherwise, you can end up with a serious condition called Addisonian crisis, because your adrenal gland goes to sleep. So that's really quite important. Hydroxychloroquine, you just stop. You don't need to worry about winding it down. So these are kind of the important things you need to explain to the patient. From a baby's point of view, now these two drugs that have been around for over 9 decades, Hannah. We have a fantastic track record on a safety in pregnancy. All these things that you read in Google about cleft lip and palate, there is no evidence for that at all. So absolutely safe for a baby. And prednisolone in particular does not cross the placenta as a kind of much. So, and therefore, it is quite safe to take. As a good example, if somebody has a chronic immune condition and they need to be on prednisolone throughout the pregnancy, if we are thinking of preterm birth and we need to give the woman steroids to help the baby's lung to mature, we don't take that into account because we know it doesn't go to the baby. So actually we give them an injection of dexamethasone or betamethasone as per our protocol to help the baby's lung to mature, because the prednisolone doesn't cross the placenta. So it's a very, very safe drug as long as it is supervised by someone with expertise. And the same applies for hydroxychloroquine. As you know, hydroxychloroquine, we use it for conditions like lupus, rheumatoid arthritis, malaria, been around for a long time. We have a fantastic record on its safety in pregnancy.
So my next question is then, when you go and look at HFEA guidelines and you look at the protocols we're talking about, they're often, well, they are red light. And, we have often had many people in clinic say they would like to explore this, but they've been told by whoever this is not a thing. They shouldn't go down this road. There isn't, and so people feel so confused
Yeah.
about what to do and where to go because there's like so many mixed messages, and I feel real empathy about how do you make a decision, to have the testing to think about this as a treatment option.
So first of all, you talk about HFA, and here you talk about IVF, not recurrent miscarriages.
Yeah, yeah,
So HFA only accounts for IVF, and here we're talking about couples with repeated failed IVF attempts, which we also look after. That's absolutely fine. The problem we have with the HFEA, and I think there's a trial now going in for funding to look at all these so-called red alerts, is it's actually doctors' choices what they do, because pre-genetic testing is a red alert, but still these IVF units do it day in, day out. So they choose things that they know there is no evidence for. Interestingly, which I find really interesting, and that's actually a reflection of how things are approached, that recently, for example, intralipid has been demoted from red to gray, while there is a lot of evidence for prednisolone and hydroxychloroquine, but they're still red. So it's confusing. My advice is, let's look at what are the possible causes of repeated failed IVF attempts. So it's either a quality of the embryo or the environment around the embryo. So if the IVF unit feels that quality of the embryo is high enough that they expect a good yield, i.e. a positive pregnancy test, then they need to look at the environment. And the environment looks like endometrial thickness, etc. And if all these are negative, then people need to stop this unexplained it frustrates patients, they use unexplained subfertility. And that's where people like me come in and say, well, actually, is it really unexplained? Let's look at other possibilities. And as you know, we look after patients with so many attempts, 15, 20 attempts of IVF. And first go, we do the investigation. We found they have an immune problem and we treat them and boom, they have a baby. Well, call that coincidental. I'm happy to take that as long as the couples are happy. So I think it is all about educating, and there is a lot of work that needs to do educating these IVF units and educating the HFEA. Remember, there's still a lot of these IVF units Clexane, they use Fragmin, they use aspirin, they use a lot of things, PGT and so on, which are all in the red. For some reason, they use them, but when it comes to immune therapy, they're denying them. I always say that if you look at the most successful IVF units in the UK by miles, what is the commonest aspect or denominator among all these units with the top three? All of them use immune therapy. I rest my case.
Okay. Thank you. So just because we were talking about IVF there, so when you would think immunology with repeat failed IVF, so you've had rounds and rounds of treatment, your treatment is just not being successful. That's when you would start to think, because again, the other issue is like, at what point do you start to think about immunology? Should you think about it at the beginning and save the partake of all those failed rounds of treatment? Or do you wait until you've had X number of heartbreaking miscarriages and then you go and test? Or do you wait until you've spent £30,000 and then you go and test it? It can be so frustrating for people that they say, why was this test not done at the beginning? Like, why was it not done earlier?
The reason I'm smiling, Hannah, we haven't discussed this before, but you're exactly thinking like me. You're just amazing. So I was really impressed with your question. This is a dilemma. So the first paper we published on natural killer cells, in natural killer cells, actually was 3 repeated failed IVF attempts. So we had that dilemma from 2004, and we said, should we actually offer this firsthand, or do we offer it as per the research after 3 failed IVF attempts? My view that this test should be done at the front, because at the beginning, because all our clients, they all say, we wish we knew that from the start. And my view is that you need to give that information to the patients, and you say to them, the research was done on people with repeated failed IVF attempts or repeated miscarriages, etc. But this test is available for you to consider doing it, and then they can decide. The same applies, for example, to hysteroscopy. A lot of patients sometimes get frustrated when the hysteroscopy only offered after 3 losses or failed attempts, and why not being offered at the beginning? So for me, I think information is power. So I empower my patients with information, and I say to them, this is what you do, this is what we do, and then you can make a decision. Now, we see ourselves as almost, because I'm not an IVF specialist. I don't claim to be an IVF specialist. We do IVF in our unit, led by my colleague, Mr. Haider Jan. But normally, the patients I see are not coming knocking on my door to have their first IVF. I wish. All of the people who come and see me, been there, done that, had the t-shirt, and they're coming really with complex history. And they always say the same thing. So for me, I think if I am running an IVF unit, I will offer it to the patients day one. They can make a decision whether they want it or not at any stage, but not wait until they have 3 losses. And sometimes we do have couples who know a sister or a friend or something who've been through difficulties, and they don't want to go through that, and they come to see us for the first time, and we do the test for them. So absolutely, you're absolutely right. And I think, who wants to spend 30K, but not the money? It's the time wasting, the heartbreak, going through egg collection after egg collection, embryo transfer. It wears you down, and it affects relationships. I've seen such awful, sad outcomes in couples who go through this. And the worst situation is that you have recurrent pregnancy loss, but also difficulty in falling pregnant. So every time you have to fall pregnant, you have to go through IVF. And that is very painful, very tiring, and affects definitely relationships. And I've had couples who eventually end up with a successful outcome, but actually by that time, their relationship broke down. And that's something also we need to address. That's not been tapped in at all.
For people listening out there, are there any signs and symptoms that might raise a flag for somebody to get testing done, so that somebody who hasn't maybe experienced a lot of loss, or they've not gone through repeat miscarriage, but is there any like things in somebody's health history or life experience that makes you think this person might need to do immune testing before they try to conceive?
Not always. Good question. So obviously, and if you do have a background personal history of an immune issue or a family history, then it makes sense to seek investigations. But at the same time, we see couples with no history at all. All the history they have is repeat miscarriages or repeat failed IVF attempts. So there is no symptom or sign that will tell us who's more likely that we will find a positive result.
Okay, that's helpful. And in terms of like the other treatments that are used for recurrent loss, so the blood thinners, the progesterone, do they have their place in this picture, or are if it's immunology, are we saying like there is no place for that?
So personally, let's look at the sticky blood situation. So there are 2 main tests we look at. Something called hereditary thrombophilias, which is mainly things like factor V Leiden, prothrombin gene mutation, etc. And there is acquired thrombophilias, which is the lupus anticoagulant and anticardiolipin, etc. The hereditary thrombophilias, that's now clearly evident from several trials. So there's a trial published in the Lancet, we published as well in the BMJ, very clearly showing that there is no link to hereditary thrombophilias and recurrent miscarriages, and no evidence for giving heparin to improve outcome. And that heparin includes clexane, fragment, etc. So that a kind of door should be closed, not even for discussion.
Wow.
The other door is about the antiphospholipid syndrome, so the so-called lupus anticoagulant and anticardiolipin. So I looked at that, and we published that in the BMJ. So if your audience can Google, Hassan Shehata, BMJ, open, thrombophilia, they will find my paper will come up and you can see it. And he said, and you can see it openly. Now, accessible. What we have found that there was only good quality, only 2 or 3 trials that looked at it properly. The majority of trials were done before classification of antiphospholipid. And what they have found that the prevalence of antiphospholipid, these tests, in the general population is between 1 to 5%. And these trials have shown the prevalence is between 1 to 5%. Now, even recently, the classification has changed. So the classification now, in the good old days, we used to say, you need to have 3 miscarriages or more, or 1 loss after 10 weeks. You have to have 2 tests 12 weeks apart. And these tests need to be at a certain theta. Now, the classification is based on clinical and laboratory. Let's say the laboratory, if you have 1 result that is high theta, you get 3 points. On the clinical, you need to have 3 points in order to be classified. What they have done now is that the miscarriages, recurrent miscarriages, have been demoted to 1 point. And therefore, you can never get score 3. So indirectly, basically, the new classification says recurrent miscarriages is not a cause of, is not caused by antiphospholipid. So for me, I stopped doing the test at all. And even if it is there, unless there are other associated clinical issues like pulmonary embolism or a DVT or a stroke, something like that, I would not entertain it. So for me, I think the sticky blood situation is closed and finished. So I would not give that. Progesterone, as I mentioned earlier, the main trial that was done with recurrent miscarriages, published in New England Journal of Medicine a few years ago, very clearly showed intervention with progesterone doesn't work. Another trial done for threatened miscarriage, so people are bleeding, but the pregnancy is viable. Also, no evidence. However, sub-analysis suggested that if you take a bit from this and a bit of that, it may work. But that's not science, really. So I don't think progesterone has a role the way we currently do it, i.e. giving it from positive pregnancy test. I think progesterone may have a role because it has an immune modulation effect, but then you need to start preconception from the luteal phase.
Mm. And just carrying on from testing, where do you stand in the microbiome testing? Because that's a big kind of new world that's exploded in fertility. And some of the courses that I do, I sit in a different world. There is a link between good microbiomes and good immune systems. What do you think about all of this?
I think it's very exciting. I think microbiome, again, wearing my maternal medicine hat, the rheumatologists are talking about microbiome, the cancer specialists are talking about microbiome, and the liver specialists are talking about microbiome. It's a new kid on the block. Everybody's excited about it. When I looked at the studies, Hannah, if I'm honest, there are studies that have shown a link. There are studies have shown no link. Again, what we're lacking, similar like with the sperm DNA, is we don't have any evidence of intervention improving pregnancy outcomes. So I am open-minded about it. I think we need to wait for the studies to come out and show us the way if that is something that should be explored. But at the moment, I will not base kind of my treatment on something that is not being properly researched. Exciting, I'm not discarding it, but we need to wait for research.
Okay, that's so helpful. So before we go, can we just discuss? So if somebody's listening to this and they're like, "Yes, I want to go down this route," tell us how people can access you, because I know you have NHS and I know you have a private ring. So if let's say somebody, I mean, privately, I presume people can just ring up and book in, so that's easy. NHS route. Can you explain a little bit about how somebody who maybe isn't in London or in the south could access you via their NHS system?
Thank you. So the NHS, my clinic is based at Epsom and St Heliers. So you need to go to the patient needs to go to the GP and ask the GP or the hospital where she's been looked after in the recurrent miscarriage clinic. They can do a hospital to hospital referral or a GP to hospital referral. We are on the choose and book system, and we're a tertiary center, and we get patients from all around England and Wales. I think Scotland and Wales, Scotland and Ireland, they have to have a special arrangement, but we also see patients coming from there because they're obviously out of the England and Wales NHS. So we just kind of get your self-referred. You cannot self-refer, so you have to go through the GP or via the consultant where you're looked after. Our waiting time is not great, but I'm training some other people to help with that. And the most important thing is to avoid pregnancy until we see you, because as we said earlier, preconception approach is really important. In the meanwhile, in the interim, try to do things like take your multivitamins, take your omega-3, take your vitamin D extra. So I would like all my patients to take 2,500 units of vitamin D. We're not a sunny country. I don't know if people have realized that. For some reason, relying on 400 units is not enough. These are all good things. And of course, then cut down your alcohol or stop it altogether. If you smoke, both as partners, they need to stop that as well. So all the kind of the things that, the well-being. There was a paper we published called, kind of like an expert group in the Lancet a few years ago. You can look it up and that will tell you what the things to do. Now, in the private sector, the easier thing to do is go through the website, which is www.CRP Clinic, which is Center of Reproductive Immunology and Practice. So C for Charlie, R for Romeo, P for Papa, Clinic, all one word, .co.uk. You can just Google my name, and then you can email or ring and make the appointment. We accept in the private sector self-referral, so you don't have to go through GP or anything like that.
And am I right in thinking that if somebody is doing IVF, say with a different clinic, they can see you alongside, so be side by side the treatment? Am I right in that?
Absolutely. We look after a lot of couples who are having IVF elsewhere, sometimes egg donation abroad, etc. Our job is to create a program that will run in parallel. So we're more than happy to see. We have a very good relationship with a lot of the IVF units.
Okay, well, thank you so much, Professor Shehata, for spending your 60th birthday talking to me and informing everybody about your work. I really, really appreciate it. I did want to say I was a bit worried because I did hear that you're a Liverpool fan and we are a United family, but we will let that go. We won't discuss football on the podcast. And I just want to say thank you so much for being here. It's been great.
Well, thank you very much, Hannah. I used to worry about United, but you're on the second page now. So now we now worry about Arsenal. And Man
Those
City.
days have gone.
Those days have gone. But thank you very much, Hannah, for the kind invitation, and really grateful and for this opportunity. And I hope I could have been some assistance to your audience.
I'm sure you will have. Thank you.
Thank you. Have a good day.
We hope you have found this helpful. If you'd like more on fertility education, please see our Teaching to Conceive free course linked at the end of the show. You'll also find the link to join our community. For more personalised fertility support, you can work with us one-to-one in clinic and online. You can book a discovery call to find out more.